Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the hernia. Hernia is the protrusion of a viscus or a part of the viscus through an abnormal opening in the body. The external abdominal hernia is the common form. Other types are epigastric, para-umbilical, umbilical, femoral, inguinal, and divarication of recti. Rare forms are obturator hernias, Spigelian hernia, superior lumbar, inferior lumbar, gluteal and sciatic hernia. The most frequent is the inguinal hernia, followed by femoral and umbilical. Any condition which raises the intra-abdominal pressure like lifting a weight will cause the protrusion. The hernia consists of three parts: the sac, contents of the sac and coverings of the sac. Sac consists of a diverticulum of peritoneum. It is divided into mouth, neck and fundus. In many cases the neck is well defined and in some cases it may not be there. The body of the sac varies in size and is not necessarily occupied. In long-standing cases, the wall of the sac is thick and may be of cartilaginous consistency. Contents. The contents may be omentum, called omentocele or epiploccele. Intestine. Enterocele. Could be small intestine, large intestine or vermiform appendix. A portion of the intestine called RICHTER'S hernia. A portion of a bladder or diverticulum of bladder, in addition to the other contents of direct inguinal hernia, sliding inguinal hernia and infemoral hernia. Ovary with or without a part of fallopian tube. MACKEL'S diverticulum. RICHTER'S hernia. Fluid as a part of ascites or blood-stained fluid in strangulated hernia. Coverings. Coverings are derived from the layers of abdominal wall through which the sac passes. In long-standing cases, they are atrophied due to stretching and amalgamation. Classification. Fundamentally, they are classified as reducible, irreducible, obstructed, strangulated and inflamed. Reducible hernia. The hernia reduces itself when lying down. It may be reduced by the patient or surgeon pressing the swelling. If it is intestine, it gurgles on reduction, and the first part is difficult to reduce than the last. In case of omentum, it is dumpy and the last portion is difficult to reduce than the first. Irreducible hernia. The contents of the hernia can't be returned to the abdomen, but there is no other complication. It may be due to the adhesions between the sac and the contents or from overcrowding within the sac. It is always suggestive of omentocele. Femoral and umbilical hernia are of this type. Long-standing inguinal hernia is sometimes partially reducible. The irreducible hernia can lead to strangulation. Obstructed hernia. It is an irreducible hernia containing intestine, the lumen of which is obstructed from without or within, without interference to the blood supply to the bowel. Symptoms are less severe and onset is gradual. Incarcerated hernia. It means the obstruction or strangulation. The term is usually used when a portion of colon occupying hernial sac is blocked with feces. Strangulated hernia. A hernia is strangulated when the blood supply of its contents is impaired and gangrene may be formed within 5 to 6 hours. Femoral hernia is more likely to strangulate due to strangulation. The intestine momentum in the sac and the peritoneum congested, thrombosed, and finally become gangrenous. Clinical features. Pain. It starts suddenly and first present over the hernia, leads to the generalized abdominal pain. The nature of pain is paroxysmal and located at the umbilicus. Vomiting. Vomiting is forcible and repeated. The patient says that the hernia has become larger recently. On examination, the hernia is tense, tender, and no impulse on coughing. The patient is ill unless strangulation is relieved. Pain continue till the peristaltic contractions cease. With the onset of gangrene, then paralytic ileus develop. Hence, the spontaneous cessation of pain is of grave significance. Strangulated RICHTER'S hernia. Strangulated partial enterocele. A portion of the circumference of the intestine is affected. It is dangerous as it mimics the gastroenteritis. Local signs of strangulation are not obvious. They may be no vomiting or rare. Intestinal colic. It is there, but bowels are often opened or there may be diarrhea. Absolute constipation is delayed till the paralytic ileus pervades. Hence, the peritonitis may occur before the operation is undertaken. Strangulated omentocele. Unlike intestine, omentum may maintain on a meager blood supply. The onset of gangrene is correspondingly delayed and occur first in the center of the fatty mass. Unrelieved, a bacterial invasion of the dying contents of the sac will occur. For some days, infection is limited to the sac. In the inguinal hernia, infection terminates as a scrotal abscess in males. Extension of the peritonitis from the sac to the general peritoneal cavity is a possibility. Inflamed hernia. The hernia is tender but not tense. The overlying skin becomes red and edematous. The inflammation can occur from the external source as a pressure from ill-fitting truss, inflammation from contents of the sac like acute appendicitis or salpingitis. If it is due to inflammation of an organ in the sac, herniotomy is a must. That's all about the hernia, and in the next video I will discuss about each type of hernia. Thank you.